Good afternoon. I'm Coralie Ray-Lanou, and I'm the Executive Director of Cancer Programs at UVA Health Development. I'm thrilled to welcome all of you to today's discussion about the transformative work of UVA's Comprehensive Cancer Center to increase awareness and inform treatment of blood cancers through the Translational Orphan Blood Cancer Research Initiative. Before we get started, I'd like to share a few housekeeping notes. Today's program is being recorded, but only presenter names and images will be visible. We will share a link to the recording following this email that can be shared as needed. We will also have time for questions at the end of this program. You may enter questions for our panel at any time using the Q&A icon at the bottom of your screen. Only the panelists and our moderators will be able to see the questions you submit. And please keep in mind that our panelists cannot provide personal medical advice during this program, but we ask that you frame your questions to be of general interest to the audience. We will be providing information throughout the program in the chat that are additional resources related to what's being shared. We also plan to send those additional resources and links following the program. Today, we're honored to have our program moderated by Dr. Loughran Ho Foster. Dr. Foster, I welcome you to turn your camera on. Dr. Foster is an associate professor of hematology and oncology at the UVA School of Medicine and a very important member of our cancer center team. As a UVA hematologist oncologist, Dr. Foster treats patients with blood disorders and blood cancers. Her clinical practice primarily focuses on the management of patients with plasma disorders, such as monoclonal gammopathy and myeloma. Now I'd like to turn things over to Dr. Foster, who will introduce today's presenters. Please join me in welcoming Dr. Loughran Foster.
Thank you, Coralie, and welcome everyone. We are grateful you're here to learn about the vital work we're doing to transform the treatment of blood cancers, giving our patients new hope. Thank you for the insightful questions many of you have already submitted for our panel today. Leaders from the UVA Cancer Center are here to answer as many of those inquiries as time allows and shed light on the Cancer Center's crucial research, clinical trials, and therapies, which are saving lives and improving outcomes for our patients across Virginia and beyond. And now I'd like to introduce you to all of them. Panel, please turn on your cameras while I introduce you. Our speakers today include Dr. Tom Loughran. Tom is director of UVA's Comprehensive Cancer Center and the F. Palmer Weber Smithfield Foods Professor of Oncology Research at UVA School of Medicine. Tom joined the Cancer Center 11 years ago and led the Cancer Center's transformation, culminating in its designation as a National Cancer Institute Comprehensive Cancer Center in 2021, the first in Virginia. He also serves as co-leader of UVA's Translational Orphan Blood Cancer Research Initiative. Tom discovered large granular lymphocyte LGL leukemia over 40 years ago and has devoted his career to studying this rare blood cancer. He is recognized widely as the world authority on LGL leukemia. Tom will share updates on LGL leukemia and research and care today. We also have Dr. Owen O'Connor. Owen is co-leader of UVA's Translational Orphan Blood Cancer Research Initiative, co-director of the T-Cell Lymphoma Research Program, and an American Cancer Society research professor in the Division of Hematology and Oncology. Owen is internationally renowned for his expertise on the diagnosis and treatment of all forms of lymphoma. He has invented and pioneered the development of multiple drugs for the treatment of lymphoma, including one that he co-invented for T-cell lymphoma, which has now been approved in over 35 countries around the world. Owen will share more about the Translational Orphan Blood Cancer Research Initiative and the progress that has been made since the initiative was launched in 2022. We'll also hear from Dr. Craig Portell. Craig is Section Head for Hematologic Malignancies and Medical Director, Hematologic Malignancies Clinical Research Program at UVA Cancer Center. Here, he holds a clinical faculty appointment in the Division of Hematology and Oncology. Craig is an expert in managing lymphoid malignancies and has spent the majority of his career studying two important blood cancers, mantle cell lymphoma, and chronic lymphocytic leukemia. Craig will be giving us an overview of blood cancers today. So I now welcome Dr. Craig Portell, to kick off our program. Craig, thank you for joining us.
Thanks, Lon. Let me share my screen. Right. So I'm really kind of meant today to give an overview of the heme malignancy section and blood cancers in general. So we'll start with just that. So the set of disorders that we're talking about today are really considered blood cancers, and they really fall into three basic categories. Leukemias are cancers that fall out of the early blood-forming cells in the bone marrow, and they can be both myeloid and immature lymphoid cells. If you look at this figure to the right here, this is a figure of the normal development from a stem cell to normal forming blood cells. And the bone marrow compartment is really comprised in my crude circle blob here, whereas these are the cells that are typically, excuse me, developed in the peripheral blood. So the leukemias would be developed out of all of these cells that are in the immature bone marrow space, whereas lymphomas tend to be cancers out of the lymph tissue space or more mature. So one of the major breakpoints is whether cells develop into a myeloid or lymphoid lineage, and the lymphomas develop into these categories here. Whereas the myeloma is the cells that are the most differentiated lymphocyte, B lymphocyte, called a plasma cell, and those are plasma cell dyscrasias. Interestingly enough, most leukemias and bone marrow failure disorders don't really develop out of the mature myeloid diseases. They develop into the more immature diseases up here. So we don't get cancers for the most part of these most mature cells. And we'll plan to discuss each of those areas, our faculty in each area, and some advances in research in the areas in a few minutes. Just to kind of get an understanding of the scope of the problem, this is the most updated estimated both incidence or number of new cases and deaths of all cancers in the United States, 2024 estimates. So non-Hodgkin's lymphoma and leukemia fall in the top 10 number of incidents in both male and female, as well as the number of deaths. But do note that leukemia does surpass non-Hodgkin's lymphoma in the number of deaths, despite having fewer cases, mostly because it's a slightly more deadly disorder, though we've made some progresses along the way. Speaking of, this is a figure that kind of demonstrates over time the number of cases per year of all the blood cancers: leukemia, myeloma, non-Hodgkin's lymphoma, and then Hodgkin lymphoma being here in the green, multiple myeloma being here, non-Hodgkin's lymphoma in the blue, and red being the leukemia. The number of new cases per year, the number of deaths per year, and then the bottom figures are based on age-associated weight. So as the population ages, we would expect those cancers that are seen more with patients who are aging, which is most of the blood cancers, to go up in incidence, is what we see here. And these two figures kind of correlate with that. Either way, you can see as a general number that we do see more leukemia and non-Hodgkin's lymphoma over time, and that does equally associate with deaths, though that curve is somewhat slowing down, at least in the leukemia side of things. So let's go a little bit more into depth into the three major categories. So leukemia is a broad term that is accounted for by four basic categories, with some details needed and more times needed to go into all of the details. But either way, we associate with four major categories: acute myeloid leukemia, myelodysplastic syndrome, which to some degree is a early a precursor, if you will, to acute myeloid leukemia, though many patients with myelodysplastic syndrome will never progress to acute myeloid leukemia. Acute lymphoblastic leukemia, which is that cancer that develops out of the early phases of a normal lymphocyte production, and then myeloproliferative neoplasms, which include chronic myeloid leukemia and myelofibrosis, as well as others. Going into each one in a slight detail, so acute myeloid leukemia is really considered as one of the more aggressive forms of any cancer. Patients can get very sick very quickly and have a very insidious onset of disease. Over time, we've gotten better and better information to classify this disorder, and now utilize those classifications to improve treatment and hopefully decrease toxicity for those highest risk patients. Really, our intention for those patients is to go to transplant and to not hurt them in the process of getting to transplant. So if we know aggressive treatments don't really work that well, maybe we can use less aggressive treatments and still be able to get a remission to go to transplant and have a good outcome. And by transplant here, I really do mean allogeneic stem cell transplant as opposed to an autologous stem cell transplant, which is using your own cells. When we're doing an allogeneic transplant, which we need to do for these leukemias, really trying to replace the bone marrow and the immune system so that that new immune system can take care of the leukemia. One major advantage in acute myeloid leukemia is the addition of a new drug called venetoclax, which is a drug we'll talk about a little bit throughout various different stages. Venetoclax has really improved on when adding to standard treatment, has improved on AML outcomes and is being used more and more for patients now. We've also been able to better identify targeted agents to these genetic classifications of the disease that has also changed outcomes and has helped patients get less intensive therapy, but still effective therapy. Acute lymphoblastic leukemia is another form of leukemia. This is typically seen in younger patients, but can also be seen in older patients, which is where it is slightly less studied. Newer additions of antibody-based therapy and immunotherapies have improved their outcomes. Two drugs come to mind, mostly blinatumomab, which is a drug that helps the normal part of the immune system identify the leukemia better, as well as inotuzumab ozogamicin, which helps to deliver cytotoxic chemotherapy directly to the leukemia cells, as opposed to delivering just chemotherapy throughout the entire body. We've also been able to get a better understanding of the genetic basis of this disease, and treating it, directing as such, has been helpful also. Myelodysplastic syndrome is really a broad spectrum of disease that we are improving our understanding for every day. Again, venetoclax has improved this outcome, and also sometimes just understanding what supportive care is needed and trying to do things like decrease transfusions, which are a very common problem with myelodysplastic syndrome. This is really a disorder that tends to present with bone marrow failure or very low blood counts that require blood transfusions. Improving ways to decrease those transfusion needs, yet still provide the patient with supportive care, has improved outcomes with patients with myelodysplastic syndrome. And also myeloproliferative neoplasms, which tend to present less as low blood counts, but as high blood counts, also a very broad spectrum of disease with many different forms. One form in particular, myelofibrosis, there's an active drug that has been developed at UVA called TP3654, which we've done some clinical work and preclinical work and is showing significant progress. One of our faculty members presented the first findings of this 2 years ago at one of our major meetings. Speaking of our faculty, this is our leukemia team here at UVA, consisting of Michael Kang, Faraz El-Shar, Mike Duvas, and Mike will come into many of these slides. Mike is our young adult expert, less of a leukemia, or he's a blood cancer expert, but he's really a young adult expert, taking care of the management of our adolescent and young adult population. We have different needs than our standard adult population, as well as Daniel Reed. Fran Garrett-Backelman is an MD PhD researcher and spends most of her time in the lab, but she also attends on our inpatient floor. She does not have a clinic, but is a well-funded lab doing leukemia research. Then we have two advanced practitioners, Amelia Hodson and Kimberly Conrad, who assist this excellent team of physicians. Moving on to lymphoma. Lymphomas also come in, excuse me, four basic categories. One very large one is the non-Hodgkin lymphoma, which is broken into 80 different categories, but some very basic categories are the indolent or slow-growing variety, which consists of follicular and marginal zone lymphomas, as well as some other more rare types of lymphomas. Aggressive lymphoma, which the typical type of aggressive non-Hodgkin lymphoma is called diffuse large B-cell lymphoma. I would put mantle cell in the aggressive lymphoma category, though it has features of indolent lymphoma, so it kind of straddles both the indolent and aggressive lymphoma category. And then Burkitt lymphoma is also one of the classic aggressive lymphomas. T-cell lymphomas, which are UVA has a center of excellence in, at least we would consider it a center of excellence, which really focuses both in cutaneous and nodal T-cell lymphomas, of which there's many different varieties. Chronic lymphocytic leukemia. Now, while it's called leukemia, it really is a cancer of mature lymphocytes. So I tend to think it behaves more like a lymphoma and acts more like a lymphoma. So therefore, I classify it as a lymphoma. That's another form of lymphoma. Hodgkin lymphoma. You know, Hodgkin lymphoma looks and behaves a lot like non-Hodgkin's lymphoma for some degrees. It does have a very specific look to it. However, it has a very specific appearance under the microscope, which is why it was described first and thus called Hodgkin lymphoma, and then everything else was called not Hodgkin or non-Hodgkin lymphoma, which is why we have a big group of classifications in the non-Hodgkin lymphoma category. And then large granular lymphocytic leukemia, which of course I will not talk a lot about because you will hear a lot more about that with Dr. Loughran later. Some major updates in this group. Probably one of the biggest ones is a class of medicines called bispecific antibodies. These essentially engage effector cells, which for the most part are T cells, to lymphomatous B cells. So this is, again, using one part of your immune system that is not cancerous to kill another part of your immune system that is cancerous, the lymphoma cells. So these directly bring these two cells together and cause the T cell to kill the B cell, and therefore we get engagement by these lymphoma cells. 3 have come to the market for diffuse large B-cell lymphoma and follicular lymphoma. We do expect more indications and drugs pending for this particular technology, which has been kind of really improved our treatments for mostly relapsed lymphomas, though we're opening a trial soon that will evaluate a diffuse large B-cell lymphoma using these types of drugs in the frontline setting. The other major advantage has been Bruton's tyrosine kinase, or just generally signaling pathway inhibitors. And Bruton's tyrosine kinase is a common pathway of addiction, of signaling addiction. Think of these pathways as the cells need their signal to survive, and there are ways to target this signal that shuts down that addiction, and then the cells end up dying on their own. We have new ways of targeting this pathway that are being studied. And we've also developed some combination therapies, particularly with venetoclax. In fact, UVA was one of the first to study Bruton's tyrosine kinase inhibitor and venetoclax in mantle cell lymphoma, and published actually one of the only frontline trials that evaluated what the optimal dose of the combination. And finally, I think one of the novelest therapies coming out in the lymphoma world are a therapy called CDK9 inhibitors. Now, these interact with the cellular machinery and help downregulate or decrease many different signals that are important for cancer cell growth. And we really are hopeful that they will provide some good benefit, though they're very early in their development. We do have a phase 1 study with one of these inhibitors that is currently open for many different lymphomas. And of course, one of the more attractive therapies for aggressive lymphoma is called CAR T-cell therapy. What CAR T-cell therapy is we essentially take out a part of the blood, the T cells, and all actually mostly blood-forming cells, and then send it to a manufacturer, a GMP facility, which we have one of these at UVA, but have not been creating our own CARs here at UVA. Either way, we take out these cells from a patient through a process called apheresis. Much like fancy dialysis, we take out the cells, the white blood cells from the patient, and we give back the rest of the blood cells. We then separate cells and activate and expand those T cells. T cells are the cells that are responsible for killing killing both bacteria, viruses, infected normal cells, cancerous cells, but we can genetically modify them so that they then attack B cells, which is essentially what we do, which is what most of our lymphomas are. And then once those are expanded, activated, genetically modified to kill B cells, we then have a product called CAR T that we then reinfuse into the patient, where it goes and finds all the B cells that are the lymphoma cells, as well as some normal B cells, and then kills those cancer cells directly, because that's the goal of a T cell, is to kill other cells. CAR T cell therapy, which is termed chimeric antigen receptor T cell therapy. Currently, it is approved for diffuse large B cell lymphoma, mantle cell lymphoma, and follicular lymphoma. We're very hopeful for an approval in CLL soon, or chronic lymphocytic leukemia. There are also new approaches to CARs, including using NK cells or allogeneic T cells. So one of the problems with CAR T cell therapy is that we have to take the cells out and then manufacture them, which takes up to 2 to 3 weeks, and then redeliver the cells. It would be nice if we didn't have to use autologous patient cells, that we can use other patient cells. And we're developing technologies to make this safe, because one of the challenges with using other people's cells is that you can get a lot of overstimulation of those T cells, though we've starting to develop some of those technologies. The stem cell transplant team has been using an NK cell off-the-shelf CAR for lymphoma. They just finished a clinical study the last few months. It should be noted that this is a similar type of approach that bispecific antibodies use, but instead of genetically modifying the T cell, they use the patient's own T cells in the body and essentially use an antibody to bring the T cell next to the cancer cell. So there is some debate in the lymphoma world whether bispecific antibodies will either improve CAR T cell efficacy or even replace CAR T cell therapy. It's kind of hard to know, because CAR T cell treatment is kind of a one and done thing. You do it once and then you're done, whereas bispecific antibodies need regular follow-up treatment. We do have some UVA-sponsored research in lymphoma. We're looking at a specific treatment for older patients with classical Hodgkin lymphoma, something I didn't talk too terribly much about. We also have a study looking at circulating tumor DNA for patients undergoing CAR T-cell therapy and seeing changes over time. And we've done some look-back approaches, not doing treatment studies for patients, but looking back at older retrospective data sets, and have done some pretty seminal work looking at older patients with classical Hodgkin lymphoma. looking at the use of chemotherapy that enters into the brain and spinal canal for diffuse large B-cell lymphoma, and then a new drug that has come to market called loncastuximab, see how that behaves in the real-world setting outside of normal clinical trials. Our team also has a robust collaboration with Dr. Jingguo Tao for translational work to identify new combinations of therapies that we hope to utilize in the future to move new treatments and new clinical studies focused in lymphoma and at UVA. Our T-cell lymphoma team is quite robust in both the nodal and cutaneous group. Our nodal lymphomas have several UVA-sponsored studies. Romidepsin and azacitidine, which is a combination that Dr. O'Connor and Dr. Markey have identified, is in clinical study here at UVA. We also have a pembrolizumab-based, which is a drug that helps to stimulate normal immune response to cancer cells. That drug is being used in T-cell lymphomas, and a clinical study is ongoing here also. There's also many novel therapies and targeted agents that are available in the T-cell lymphoma world. And then, of course, we do have a very robust cutaneous T-cell lymphoma clinic. For some reason, T cells like to stay in the skin, and a good portion of them are mostly skin-involved alone. We have a specific clinic at UVA that is in concert with dermatology. So essentially, a dermatologist and a medical oncologist go into the room at the same time and help the patient with their cutaneous T-cell lymphoma. It's really the only multidisciplinary clinic in Virginia, and it expands all the time. This is our lymphoma faculty, composed of myself, Emily Ayers, Enrica Markey, mostly focused in T-cell lymphomas, Mike Duvas, again, who takes care of our more young adult patients. Mike Williams has mostly retired from clinical practice, though is still seeing some consults here and there. And of course, Dr. Loughran, who is our expert in T-cell LGL, and we'll be talking later. Nate Roberts will be joining us in August. He's one of our clinical fellows at UVA and will be staying on as faculty and can join our group. And finally, the myeloma and plasma cell dyscrasia team. Myelomas are disorders that are the most mature form of B-cell lymphocytes. So they're the most mature B-cell lymphocytes called plasma cells. And their job is to secrete a normal protein that helps prevent infections, bacteria, viruses from infecting a patient before it actually infects the patient. Unfortunately, these plasma cells can then, when they become cancerous, can just continue to secrete the same protein over and over again. And we call that an abnormal or monoclonal protein. And that's what these myeloma patients can see. They can get problems from these proteins as well as from the plasma cells themselves. Plasma cells like to sit in the bone, and plasma cells can weaken bone. And we see a lot of bone lytic or kind of chunked out lesions from the bone due to these plasma cells. Multiple myeloma is a bit of a spectrum, going from monoclonal gammopathy of undetermined significance, or we can identify this protein but don't really see a whole lot of the abnormal plasma cells or causing any other secondary issues, to smoldering myeloma, in other words, almost causing issues, to multiple myeloma, frank cancer, to something quite severe called plasma cell leukemia, where we see these plasma cells in the bloodstream. There's also a disorder called Waldenstrom's macroglobulinemia, which borders between lymphoma and myeloma. It's the next phase of a lymphocyte getting into a plasma cell. It's a disorder of that and has specific problems regarding that. Some updates in myeloma, really understanding and risk adapting based on our clinical and genetic features is a prominent part of the new wave of this disease. Treatment is often done in phases for myeloma. So there's an upfront or induction treatment. We then tend to consolidate with a stem cell transplant from yourself. Now, this is a transplant that's really meant to give you high doses of chemotherapy and then salvage you from the effects of the chemotherapy by utilizing collected stem cells from prior to giving that high doses of chemotherapy, and then some maintenance therapy. There have been several new drugs that have been approved in multiple myeloma, and these are being studied in the relapse. They have been approved in the relapse setting and are being studied earlier and earlier in the line of therapy. We've also developed some bispecific antibodies, and CAR T-cell therapies are really at the forefront of some of the updates in myeloma. Research at UVA is really focused on bringing these novel therapies earlier in the lines of therapy. So some of the big questions that are being asked with some of the studies at UVA is, can CAR T-cell therapy be used instead of the high dose stem cell transplant as consolidation? Another question is, 4 drugs induction better than 3? Can we shorten the maintenance therapy, maybe by utilizing some specialized tests called minimal residual disease testing to prevent patients from indefinite maintenance, and then stop using maintenance therapy, using minimal residual disease testing to stop therapy? And then can we add new therapies to maintenance therapy that can also help decrease that therapy? Our faculty in myeloma are John Dinsmore and Lon Foster. You all know Lon Foster, she just talked earlier. And that is the faculty for the heme malignancy section. I can't end a talk without talking about our cellular therapy faculty, which is headed by John Wagner, as well as Karen Ballin. Karen is the division head for hematology and oncology, but Dr. Wagner runs the stem cell therapy faculty. Other faculty members are Indu Varadarajan, as well as Dr. Leonid Volodin. And then Krithika Shanamagasundaram joined us late last year and is getting her clinic ongoing and quite robust. Our nurse practitioners are Jess Kasey McAllister and Hanya Alol, who also round out the team. And with that, I'd like to thank you, and my email's there if there's any questions or concerns. Thank you much.
Thank you, Craig. My name is Owen O'Connor. As you heard, I'm the American Cancer Society research professor, and I've been at UVA now, developing a team very devoted to trying to change the treatment paradigms for these very challenging diseases. I want to thank you all for taking time to join us today for what I think is promising to be a very interesting introduction to the work we're doing. We thought it was important to introduce you to this concept of translational medicine and how we at UVA believe we are uniquely poised to address the unmet medical needs of some of the most challenging cancers that exist. Why do we think it's important to introduce you to this concept of translational medicine? One, because it's absolutely critical in our ability to leverage the latest advances in basic science and try to find ways to apply them to patients in a way that help us care for and manage patients in a much more efficient way. And secondly, because actually the team that has been built under the leadership of Dr. Loughran and Mike Williams at UVA has really been one that has intensely focused on this very important aspect of clinical research. Can everybody see my slides? I hope this is good. So what is translational medicine? And one way to think about it is that in the world of scientific research, there are basically 2 languages. You can think of them perhaps more as dialects. There's the dialect of basic science, and there's the dialect of clinical medicine. Unbelievably, if you put a bunch of basic scientists in a lecture of being given by a clinician, they would probably all go to sleep or not understand much, and vice versa would also be true. In fact, if you look at the areas of focus for basic scientists, they tend to focus on things like cells, the components of cells like nucleic acids and genes. They tend to focus on proteins and how different proteins communicate with each other and how those communicating pathways create networks. So they focus on some very basic features of cellular biology. They try to answer questions like, how do normal cells behave, and how and why do abnormal cells misbehave? In the dialect of clinical medicine, the focus is really different. The focus is on disease, epidemiology, diagnosis, prognosis, and treatment. And clinicians try to answer questions like, how do we manage patients suffering from an illness? How do we diagnose them better? How do we prognosticate better? The world of translational medicine fits snugly right in between the two. The translational physician scientist actually understands the dialect of both of those languages. They understand and function in the world of basic science and clinical medicine. They try to figure out what are the concepts and principles from basic science that are most important to try to relate and apply to a patient. And they try to answer questions like, what scientific principles are likely to make a difference in the natural history of a given disease? And the team at UVA that I just mentioned, built by Doctors Loughran and Williams, has really been focused on embellishing all three aspects of this. And most universities have good basic science, good clinical medicine, but what they really lack is that piece in between that catalyzes the transfer of that important information that directly impacts the lives of patients. And in fact, if you read about this area, you'll see that there's a lot of concern that we as a country and we as a global community in cancer research are not doing a good job generating translational research scientists. And as the scientific advances continue to accumulate and grow, there's a concern that we're not going to be able to leverage those advances in the ultimate way to help our patients without having enough scientists focus on the translational aspects. So it's a crucial part of our ability to actually change diseases and help patients. And so what are some examples of translational medicine? And I have no doubt that you all know some examples of these, but you probably don't realize how important the translational physician scientist is in moving a basic science concept all the way to application in a patient. Diagnostic tests, for example, improve a physician's ability to more precisely diagnose a disease. Maybe that evolves around a gene, maybe it revolves around a protein. But it starts with some understanding of basic biology that's then applied in a statistical way to the care of patients. Prognostic tests are also similar to that. They improve a physician's ability to precisely define any given individual's risk from a disease, like minimal residual disease. You just heard Dr. Portell talk about CLL and mantle cell lymphoma, where those are two diseases where the ability to measure really small levels of disease that the CAT scan cannot see are incredibly important in trying to stratify patients who we would predict will do well and help differentiate them from patients who might not do well. Implantable devices like defibrillators improve physicians' ability to intervene with a mechanical intervention. And in the fourth area, the one that I'm going to talk about a little bit more, involves the development of drugs. And as you might imagine, the science behind how to target a protein or a gene with a small chemical is actually very dependent upon a tight relationship between drug developers, chemists, biologists, who would then think about how to move those drugs and that science efficiently to the patient in a way that improves the outcome of the patient. And this would be an example of essentially any drug you would take fits this particular paradigm. And so when you think about steps involved in translational drug discovery and development, I've shared with you a fairly simple schematic. Trust me, it's never this linear, nor is it ever this simple, but it's here only to underscore some of the major pieces of what it takes to put together a translational team. You start all the way in the upper left side with really great chemistry. We'll talk about great chemistry, but it can involve scientists who develop antibodies or scientists that develop engineered T cells. Whatever you want that drug to be, you need to start with sound science that supports a rationale for further development or understanding of that particular drug. There are in vitro assays that are used to understand and answer questions like, how does my drug kill a tumor cell? What are the effects of my drug on that tumor cell? Am I hitting the target in that cell that I postulated was important from the outset? What's the mechanism of action? Does it do what I think it does? Does it do other things in addition to the things I thought that drug was designed to do? So understanding mechanism of action requires us to delve deeply into cancer cellular biology. And after you have those concepts sort of understood, you then try to apply them to an in vivo model. And before jumping to people, we often use small rodents to try to understand, how do we model that drug in a way that helps us now translate from those observations directly to the patient? And they're absolutely critical, and I'll show you an example. Then, as you heard, when we are comfortable that the science is vetted, we understand how best to give the drug, we then take it to patients in the form of clinical trials. Those trials may start out as phase 1 and phase 2, so we can understand the parameters around how best to give the drug. And then, assuming we're successful, we have to take it to the FDA and convince them. The FDA's sole responsibility, or one of their major responsibilities, is to make sure that we do no harm. So it's their first purview to make sure that what we develop in the laboratory is actually safe when given to patients. And if you're successful, on the right side, you'll see an example of several drugs that I've had the privilege of being involved in. And then they get picked up by a small biotech or pharma company, where they're then commercialized and then distributed to patients around the world to help them tackle the disease. This timeline seems short on the slide. It's actually one that probably costs somewhere in the area of hundreds of millions of dollars to go from beginning to end, and is known to take upwards of 7 to 10 years, sometimes longer, depending upon the disease. And so what makes the team that we have assembled at UVA so unique? And I've been doing this a long time at a lot of premier centers around the country. And for me, the take is that we are an incredibly well integrated team with remarkable focus. That integration is seamless. It involves weekly meetings with chemists, cell biologists, molecular biologists, and clinicians, all bringing their specialty, their dialect, to the table and teaching us how we're going to leverage their expertise and skill sets in ways that allow us to draw a unified picture with all those interdigitating pieces of the puzzle coming together. And in our particular case, and it's only our case, there are many examples at UVA where scientists have built translational teams focused on other diseases. But today you're hearing about the focus in blood cancers. And we'll talk a little bit about some of those blood cancers and how this team is coming together with focus to really try to meet an unmet medical need in this particular area. So let's talk about the enemy. The enemy in this case is a group of diseases that were referred to as PTCL, or peripheral T-cell lymphomas. And this is a disease area that I've been involved in now for a couple of decades. And it's a disease area that has truly evolved over that period of time in substantial ways. The first point I want to make is you'll see at the top non-Hodgkin's lymphoma. And I'm not going to go into too much excruciating detail about these diseases, other than to say they're largely broken down into one of two subtypes, either B-cell neoplasms or the T-cell neoplasms. And you heard a little bit about the B-cell neoplasms earlier. There's no question that over the last 10 to 15 years, we've made remarkable strides improving the outcome of essentially every patient with a B-cell lymphoma. Sometimes the addition of 1 or 2 drugs is all we need to make those diseases much more treatable, improving overall survival. However, the T-cell lymphomas happen to now represent the poorest prognosis of any kind of blood cancer, and they happen to be a group of diseases where we have not made any progress now in over 3 decades. They're a pretty complex group of diseases. The current classifications now recognize over 36 subtypes. But what I want you to look at is that panel on the lower left side. If you take all the peripheral T-cell lymphomas together, there's only about 10 to 15,000 cases per year in the United States. Guess what? There are only about 15,000 medical oncologists in the United States. So if you spread these diseases out like jam on bread, each medical oncologist would see one case of T-cell lymphoma per year over their career. Now we recognize 36 subtypes. So in theory, if you were to see one subtype each year, you'd have to be in practice 36 years to see all subtypes. What that really means is that most doctors may go through their career seeing only a handful of these cases. And so carving out a specialty in these diseases by contributing to the pioneering developments in the disease is critical as we try to build that expertise to understand these diseases and then create a patient base that wants to come learn about what we're doing so we can begin to explore how best to apply those scientific principles to patients. So this is not meant in any way to intimidate somebody that might be watching that might have these diseases. This is retrospective population data. And I put it up only to underscore the point that when you look at these diseases and you compare them and contrast them to our experiences in B-cell lymphoma, we've not made much progress. So for patients with these diseases, if you have your first relapse, the second progression-free survival, that is, how long do you go before you progress again, is only about 3 to 4 months. Survival for patients in that relapse is actually considered extremely low, in the order of about 6 to 7 months. And so this is a disease where we really need to focus. We really need to have a well-integrated team that is dedicated to trying to change these statistics rapidly and in a meaningful way. And as if everything I just told you wasn't enough of a challenge, guess what? The FDA now has new authority, as given to it by Congress recently. Authority that is now allowing it to enforce older statutory requirements that some companies have perhaps not paid the most attention to. The upside of that legislation is that it's actually now leading to a withdrawal of drugs available for patients with this disease. So failure of different pharma companies that have the responsibility for the development of these drugs and obliging the requirements of the FDA is now leading the FDA to pull some of these drugs from the market. And that's the case with the second one down, called romidepsin. And actually 2 of those other drugs, pralatrexate and belinostat, are being threatened and are in jeopardy of withdrawal. So the first 3 are the drugs approved for patients with relapsed or refractory peripheral T-cell lymphoma. Well, with the removal of romidepsin, we just lost 33% of our drug armamentarium. And at risk is 100% of the risks of the drugs that we use to treat these diseases. This, coupled with everything I just shared about these challenging diseases, makes our mission absolutely critical. And so how have we chosen to attack this problem? Well, for the last 15 years or so, I've worked with great collaborators at Rockefeller, Sloan Kettering, and Columbia. And we've developed, you can see in the first 2 panels on the left, strategies to identify ways to identify combinations of unique drugs that work in a fashion that's more effective and theoretically less toxic. I'm going to spare you a description of that science on the left, but suffice it to say that in the 2 examples where we have taken output from this scientific side of the equation and applied it to patients, you heard about azacitidine and romidepsin. So that's a combination my team has been developing for the last 10 to 15 years. That combination, identified through this platform, has produced the best data ever seen for patients with relapsed peripheral T-cell lymphoma by a lot, and it's also been shown to be comparable or better than, small numbers of patients, than the conventional standards of care with upfront chemotherapy. But what I'm going to talk a little bit more about is that panel on the right side. And that is I'm going to introduce this concept of nanomedicine, the ability to take the output from that science on the left and to embody it to create brand new drugs. And this nanochemistry platform I'll introduce in a moment, but it's one that University of Virginia happens to have a long-standing, important historical contribution to this field, having pioneered many elements of this with some of the most outstanding chemists I've ever had the privilege of working with in over 25 years. And so what is nanomedicine and nanochemistry? Again, suffice it to say, this is a huge area that we could speak to for a long time. But imagine the ability to create a particle the size of a virus. And imagine that I can engineer that particle to embody and hold and capture drugs of whatever desire I have to put in. And imagine further that I could adorn the surface of these particles with honing motifs, with ways to GPS devices that might allow that particle to go right to the tumor cell I'm interested in killing. This chemistry capability is actually one that's burgeoning now. And actually, without this technology, the well-known mRNA vaccines that you've heard about used to create COVID vaccines wouldn't be possible. It's this precise chemistry that allows scientists to protect the mRNA from the COVID virus so that it can be delivered in a high integrity way to help generate an immune response in the patient. And what we know from this field already is that the ability to integrate various strategies and techniques in nanomedicine can transform the behavior of a drug. It can make it safer. It can make it substantially more effective. It can improve its pharmacology. And from a business point of view, it creates strong intellectual property so the institution can help capture and redound some of the costs for the investment made to create the drug. We can actually put multiple drugs in a single nanoparticle, and it would be still referred to as a single drug, but this concept of creating combinatorial therapies is important, as is the honing feature. So this particular science is an area where UVA has been a pioneer now for a long time, and one we are now leveraging in a very clever way, I believe, to create new drugs to target these diseases. And so what's one example of that? Well, I showed you in one of the previous slides a drug called romidepsin that the FDA pulled from the market because of clinical trials that didn't meet the statutory requirements of the FDA. So our platform, as I mentioned again, has demonstrated we can identify combinations that can change the natural history of these diseases. So we have begun the arduous journey of making the nanotherapeutic derivatives of many of those drugs that we've identified as being most active in T-cell lymphoma. And I don't want you to be afraid of the science. I want you to look at it and get it. And what I want you to look at first is this curve on the left. And the concept is simple. On this vertical axis is the concentration of drug, and on the horizontal axis is time. So when you give some dose of the drug to an animal, you actually measure the drug in the blood, and you then plot it as a function of time, what the concentration is. And you can see that when we take the nanotherapeutic version of romidepsin, you can see that we achieve a 30-fold greater exposure to the drug than when we use the previously approved FDA version of the drug. So this is data that's been produced by Ipsita Pal, one of the scientists in our group, and Dave Feith. And it is important because it's really telling us that we can change pharmacology despite the fact that they got the same dose. But your concern would be that if you expose an animal to 30-fold more drug, you got to be concerned you're not also increasing toxicity. And in fact, if you look at the graphs on the right, what you'll see in the top panel is weight loss. So loss of weight in a mouse is actually a sign of toxicity. And what do you see? That red is actually those mice that received the FDA-approved version of romidepsin, and green is the new drug created at UVA. And what do you see? No difference. I can give the mouse 30-fold greater exposure to the drug and not get a proportional or commensurate increase in the toxicity. That's a good thing. And at the bottom, you see clinical score. Here, the higher those bars, the greater the toxicity. And again, if you look at the control, just a ghost particle with no drug in it, not much tox. You look at red and you look at green, not a big difference. And this is a very important fundamental finding that actually is very encouraging and exciting for us, because our expectation from developing a drug to which a tumor might be exposed to by a lot more without increasing the toxicity should increase efficacy and, in this case, the benefit from the drug. And in fact, lo and behold, that's exactly what we saw. So here's a curve. On the vertical axis, again, is survival. On the horizontal axis, again, is time. And this is called a Kaplan-Meier curve. It's looking at survival. And it's the gold standard when you're making drugs to improve the care of patients with cancer. But what do you see? So the vehicle, meaning just water, basically, produces this curve in blue. The ghost particle in red has just the nano shell without any drug in it. And free romidepsin is the drug previously approved by the FDA. Doesn't look a whole lot better than the vehicle or ghost, does it? But believe it or not, the purple curve is the drug that we made in the laboratory at UVA, is producing a highly statistically significant improvement in the overall survival of these mice. Same dose, same drug, except in our package with these nanotherapeutic derivatives, it's actually shown to be safer, improving pharmacologic variables, and is proving to be highly efficacious. I can't tell you how much work it takes to do this, nor how expensive this is. One mouse, and we probably use 50 at a shot, one mouse is about $250, and we use about anywhere from 5 to 10 mice per arm, with about 5 arms typically. So this experiment is, forget the time and effort of the scientists. Well, another remarkable feature of this technology is that those particles that we're synthesizing and making can actually home to the tumor. So we have the ability to take those nanoparticles and build into them a dye that fluoresces, a dye that now allows us to do something you couldn't do with your average small molecule, and that is track it throughout the distribution of the animal. And lo and behold, when you take out the various organs, you can see the tumor is the only thing that lights up, meaning the tumor is the only place where that nanoparticle resides. The lack of drug hitting these other vital organs is suggestive of the fact that we're unlikely to see those off-target effects in other vital organs. And this is a very, very important feature of this class of drugs and our ability to re-engineer them. Well, where are we? Well, I only shared one drug with you. And over the last, 18 months or so, we've actually created maybe 5 or 6 or 7. And right now we are in the process of moving our first drug to the arm, from atom to the arm. We're able to now think about trying to satisfy what are referred to by the FDA as IND enabling studies, because it's our goal within the next 12 to 15 months or so to begin clinical trials with that drug. And we have a host of others right behind it. I showed you only the simplest of examples that I had access to. And we have new insights that maybe some of the drugs that we're developing to treat T-cell lymphoma, because we're thinking like scientists and cancer biologists, could have a potent application in other incredibly challenging and hard to treat solid tumors. So we have an ambition that we're just beginning, which is moving from science to in vitro, to mouse, to pharmacology, and now in this next step to people. And so some of you may look at this and say, yeah, he's a good talker. Yeah, okay, interesting science, but show me what you're doing for a patient. And this is just one example. So this is a drug I had the privilege of co-inventing with a good friend of mine at Sloan Kettering years ago called pralatrexate with Frank Sirotnik. And this is a patient who lived in Canada. He was a Saudi gentleman, and at the time he might have been 22 years old. And this gentleman had, this is a CAT scan. This is your lung. These are the vessels above your heart. Over here is your armpit. And you can see a huge lymphoma here. And this patient got standard frontline chemotherapy with CHOP. Didn't work. Tumor didn't go anywhere. Then he got second line therapy with something called DHAP, much more toxic. Didn't go anywhere. Then they tried ICE, another regimen. The poor 22-year-old received 11 different chemotherapy drugs and radiation therapy. And so in Canada at the time, he was told, there's nothing else to do, we're sorry. And he was sent to hospice at 22. He went, he set up a rocking chair in his bedroom, I'm not joking, and he just stayed there with the blinds closed, didn't want anybody talking to him. His uncle called me and said, you know, my nephew has this bad disease. We see you have a drug. We'd like to come down and we'd like him to get it. And he was a candidate. And so what I'm showing on the top is a CAT scan, but the gentleman, over a period of only a couple of months, maybe actually even weeks, had the disease disappear. On this left side here is actually dead tumor because the tumor was growing so fast, it outstripped its oxygen supply, so it died. But over time, the tumor completely disappeared. His first ever complete remission in the setting of having had our 11 best and most toxic chemotherapy drugs for his disease. Well, I got him into complete remission and we took him to a transplant. Canada said, guess what? You're not allowed to go to transplant from hospice care. So we had to spend a lot of time convincing the government and their nationalized healthcare that he needs a transplant to be cured. This story was one that happened 16 years ago, and he is now a high-functioning gentleman and is approaching now his 40s with I hear a very beautiful girlfriend and doing very well in his career. This one drug saved him when 11 of our conventional drugs didn't. So for those of you who think that a lot of this is fantasy, it's not. This is a direct impact on a patient, and it's only one patient of many stories I can share. And so this team that we built at UVA, this blood cancer research team, really brings unprecedented talent to a form of lymphoma that's really not being addressed by industry or government because it's rare. It doesn't make people a lot of money and it's not so common in the population. So it gets neglected. It's a highly integrated and focused team that's produced already many, many drugs that I believe offer the prospect of being transformative. And really, it's under the leadership of Dr. Loughran and Mike Williams, who have been putting this thing together for a long time, and myself bringing 100 years of experience. I won't argue that we all bring the same number of years. Some bring a lot more than others, but it's 100 years of experience in translational medicine that's being brought to bear on these very challenging diseases. And we're making these drugs in a matter of months to a year, not the usual 6 to 8 years that it takes to do this. And so as a team at an academic universities, we're really poised now to move these drugs from the bench to the patient. And research is not cheap, and we feel it's really incumbent on us to educate all stakeholders as a key to our future success. And so by way of leadership, this team, I happen to work with two great friends, Francine Foster from Yale and Won-Suk Kim from Seoul, Korea. And this meeting's been going on now 15 years. It's the world's premier meeting on these diseases. And just this year, given all of the exciting advances and work being done at UVA, UVA is going to be sponsoring this meeting this coming June. And it's just another example of this team's commitment and leadership in the field to really make sure that we make these advances in a very timely and efficient way. So I'm going to actually end there and introduce Dr. Loughran, who probably needs no introduction, but I'll introduce.
Thank you, Owen.
Yes.
Yeah, thanks, Owen. Yeah, I'm going to spend a few minutes talking about LGL leukemia, but wanted to really emphasize how excited we are that Dr. O'Connor joined the team, and we have a number of new candidate drugs that will be available for patients in a short time frame. So if we go to the next slide, please. So at 100-year cumulative experience, I contribute 40 to that by discovering LGL leukemia back in 1985. And on the next slide, shows the way we make a diagnosis, which is on the left, clinical context. But basically, this disease is characterized by having too many LGL. LGL stands for what they look like. They're large granular lymphocytes. that are clonal. And so on the next slide, you can actually see what they look like. And this is how we made our initial observation, was a fellow at the Hutch in Seattle, by looking at the blood smear. It's a very important part of our evaluation of all our patients with blood diseases. In the middle are 4 large granular lymphocytes. In context, all the other cells in this picture are red blood cells. Lymphocytes should be as big as red blood cells. So these are twice as big as normal, and they have these granules in the cytoplasm. So that's how they got their name, large granular lymphocytes, easily identified by looking at the blood smear. And on the next slide, if you happen to do a bone marrow, we don't necessarily need to do a bone marrow in every patient, but on the right, these cells are stained with a marker that recognizes killer T cells. And a very curious finding is that the LGL cells line up in a singular array, it's called, right around the blood vessels in the bone marrow. This is a very classic presentation of LGL leukemia and finding in the bone marrow. On the next slide is a really interesting feature of the illness, and I still see patients in my clinic every Tuesday, but they have many different clinical presentations, including low blood counts. But really interesting, on the first point here is autoimmune diseases. They often have typical rheumatoid arthritis. And then on the next slide, just to summarize the clinical presentation, patients with LGL leukemia have too many of these cells compared to a normal person. These are normal cells in the blood, but they are expanded in number, and they're abnormal because they form a clone. Clone means one cell becomes abnormal, and then it copies itself exactly over and over and over again. On the second bullet point, the patients get sick because they have low blood counts, a low neutrophil count, or low hemoglobin, neutropenia, or anemia, respectively. They often have large spleens. The LGL cells go to the blood, the bone marrow, the spleen, and to a lesser extent, the liver. There are multiple blood abnormalities with autoantibodies being formed that can attack your own tissue. And the most typical disease that's an autoimmune disease is rheumatoid arthritis, often referred to as Felty syndrome, but LGL is very much like Felty syndrome. So that's the clinical summary. On the next slide, I'm going to briefly tell you a little bit about what we've done over so many years. Basically, the problem with the disease is that they're living a long time, and their working is killer T cells. So a really early example, way back in 2008, on the next slide, you can see kind of an algorithm. You might even call this artificial intelligence. 15 years ago, was trying to figure out how thousands of genes interact in pathways that keep the cells alive. So the important point here is that all the nodes of the pathway that are abnormally turned on are in red, and then green is abnormally turned off. And so the cells don't really die. And IL-15 and PDGF are really the most important drivers of this illness. On the next slide, our fundamental finding way back in 2001 is that the reason why these cells are alive is that they've turned on this STAT3 gene, and it's mutated. And the next slide, sorry, if we go on to the next slide, yeah, which is flashed up here. This is our seminal paper from 2012. We now know that about more than half the patients with LGL leukemia have STAT3 gene mutated. So it's very characteristic of this illness. And then on the next slide is a summary of our research that's ongoing in the lab. We're trying to correlate STAT3 mutations and other genetic abnormalities. Importantly, these are acquired, so they're not hereditary, but there are a number of clinical features that are correlated with whether or not STAT3 is mutated. The second bullet point shows our current research of looking at other genes that are mutated. And then lastly, pathways that are abnormally turned on, and JAK-STAT is the one that's most prominent. I think on the next slide, you'll see a summary of our philosophy for treatment, and that these are basically activated killer T cells that are living a long time, and we want to kill them off. And so the treatment that we use, that's summarized in the next slide, is not chemotherapy, but it's immunosuppressive therapies for LGL leukemia. And that was the only still large study published by ECOG. If we go to the next slide, I think we'll just skip through that and go to the last couple slides and for time consideration. So here's the standard therapeutic approach, which is pick one of these three. All of them are medicines designed to turn off the immune system. And so they are low doses of methotrexate, still my first choice, Cytoxan, second choice, and cyclosporin, which is the most powerful of these three, is my third choice. And this is what would be considered standard therapy. However, we know from our clinical trial that one unfortunate point is we cannot cure any of our patients with these therapies, even though we can get them into remission. So on the next slide, it just summarizes some new trials that are going on at UVA. And there's really two major categories here. One is a STAT3 inhibitor produced by a company called Chimera Therapeutics, a new technology that basically degrades or eliminates STAT3 wherever it may be in the body. This protocol is phase 1, activated at UVA and a few other places across the country. And then also somewhat promising is a totally different concept, is designing antibodies that will go through the body, recognize wherever the LGL might be, bind to them, and then kill them and destroy them. The first one on the list here is been active at UVA, and the second one is a different antibody, a similar concept that is active at other places in the country. We don't have it open here at UVA. So I think we can move on next to Lon Foster, our host for the day, and entertain any questions that anyone might have. Thank you for your attention. Really appreciate everyone coming together to listen to the great progress we're making on blood cancers at UVA.
Thank you, Drs. Portell, O'Connor, and Loughran for those updates. We hope you all have learned more about the world-class research that's being done right here in Charlottesville and the impact it's having on how we treat blood cancers and now and in the future. So now I'd like to invite all the panelists to come back on the screen so we can begin our discussion. I have a few questions to get our conversation started, and then we'll turn to questions from the audience, both those submitted prior to the program and questions that have been submitted during the presentation. Just remember, you can enter your questions at any time using the Q&A icon at the bottom of your screen, and we'll try to get through as many as we can. So first, Craig, what is new and exciting related to immunotherapies for blood cancers?
I think probably one of the biggest things is the bispecific antibodies that are being developed for not only B-cell lymphomas, but other types of lymphomas, and even some leukemias. And like Dr. Loughran mentioned, some LGL and T-cell targets that are also being developed. Also, evaluating ways to direct those CAR T cells in a different manner, I think, is another very exciting next step in immunotherapy and blood cancers.
Great. Thanks, Craig. And Tom, are there any other new treatments that are being developed that you know of for blood cancers that the audience might want to know about?
I think we covered a lot of them. I think one concept that the audience should appreciate is that over the past 10 years or so, as the concept of precision or targeted medicine has proven to be successful, primarily in heme malignancies, is we're moving away from chemotherapy, and we're moving more towards these targeted agents alone, alone without chemotherapy, but in combination they're very effective and probably as good as chemotherapy. So that's one kind of big change in the field over the last decade. And then second one, I just want to reemphasize the nano formulation products that we have for that we're developing with Owen and our nanotech team here at UVA for application for T-cell leukemias, lymphomas. We already have clinical trials completed in solid tumors and opening some nanotechnology trials in AML also.
Great, thank you. And Owen, a question for you. How is private philanthropy helping to support the development of new therapies?
Yeah, that's a great question. When you follow the traditional routes for funding in research, the traditional route would be write a grant, send it to the NIH or NCI or FDA, and get money. One of the hard truths about getting highly competitive grants is you need to have most of the data. The rule of thumb people love to joke about is you need about half the data done when you write the grant, right? So you have to have a lot of strong preliminary evidence. And so a lot of those more robust and prestigious grants are not going to fund theories without evidence. And so the value of the philanthropy is it allows you to pursue these high risk areas that can have very high payoff, significant high impact payoff. But they really allow you to get that preliminary data, which then makes you super competitive for some of those more prestigious grants. So if you view it as a component of the equation in terms of all the ways you try to sequence funding to get money, it's absolutely critical, especially for a proposition like ours, where the goal is to make drugs. And there's not a lot of places that can make drugs. And you might imagine you need talented scientists and chemists and equipment and lab space and lots of reagents. And it's a very expensive proposition. And so this seed funding is absolutely mission critical in terms of being able to generate that proof of concept that allows you to move to the next step through the more traditional routes of funding.
Very nice. Thank you. Thank you, Dr. O'Connor. So right now, I would like to just pivot a little bit and turn to some questions that were submitted before the program. And I'll start with one to kick us off. One question was, can I share more about the latest promising treatments for multiple myeloma? So to just quickly touch upon that, it's very exciting times for myeloma. I'm very excited about the drugs that have been approved over the last couple of years since 2021. We have 2 CAR T-cell therapies that you've heard from Craig about CARs. They're both targeting something called BCMA maturation antigen, and that's approved in 5th line therapy. So it's very exciting with response rates of like 80% or even like 97%. And what they're doing now is looking at that in earlier lines of therapy. So that's great. The other thing in terms of other promising treatments for myeloma are the bispecific antibodies. Again, something that Dr. Portell touched upon, which are again targeting BCMA. And that is something that we also offer here. So teclistamab and talquetamab are something that we can give our patients. And just again, in terms of CAR T, which is something we haven't been able to do for myeloma at UVA, I will let the audience know that we now are able to give CAR T for myeloma now. So that's great. So that's one question. The next one I have for Craig, what are some of the first symptoms of blood cancers that would indicate the need to seek medical attention?
Well, that's quite a broad question, a broad set of disorders. It can be anything from what we classify as B symptoms, so fevers, chills, sweats that are unexplained, so you can still get the flu, and that's not that's not a blood cancer. Weight loss, any new aches or pains that may be related to or unrelated to anything else. And then some swollen lymph nodes in the case of lymphoma. In the case of myeloma, it can be kidney failure, bone pain, bone disease, some symptoms of high calcium, which can be confusion, dehydration. For leukemias, it can be bone pain or aches in the bones, bleeding, bruising that is unexplained. That's kind of the large amount of them. I would say most new symptoms should be, that are chronic, are always something to be evaluated and by a doctor to assess what they are, whether they're benign or potentially something related to one of these disorders.
Thanks, Craig. A question for Owen. So why should someone get a second opinion after an initial diagnosis? And please, if everyone feels, if you have any other comments, please do chime in. And why should that person consider getting that second opinion at UVA?
Yeah, that's another great question. And I would argue that second opinions have two immediate values. One is the diagnosis right? So when you're talking about rare diseases like the ones this team takes care of, and I gave you a taste of that, with T-cell lymphoma being only 15,000 cases a year, experience has a lot to do with this, right? So if you see one case a year and you're that person that walks in and you're that one case that year, you don't want your doctor having to look on the internet to see what Tom Loughran, Owen O'Connor, and Greg Portell said you should do. Why not go to the people that have the experience and let them tell you what they should do? Because when you're dealing with rare diseases, experience is everything. 36 subtypes, 15,000 cases a year. The average physician in the community doesn't see enough of these cases to be able to opine with all of the latest at their disposal. And that's not to impugn them. It's simply to say, this is the odd professional career we chose, and that's what we do. The second is pathology. Everything that I do as a treating physician depends on what the pathologist tells me. If the pathologist sees one case every 2 years, then you're going to get that kind of experience injected into the diagnosis. And so not only are you seeking expert opinion on clinical management and putting the picture together, but it's what the pathologist says. So when you go to a huge referral center like UVA, you have a lot of doctors like Loughran and Portell and Williams and myself and all the others doing this. The pathologists get inundated with these rare diseases. So in their own right, they become expert, even in myeloma ear disease, another rare disease. These pathologists become very expert at looking at the details that actually make a difference in our ability to think about the right therapy, tailored for the patient, and not simply thinking about how to bucket patients into one big category of treatments.
Thank you. Well, I think we're definitely running out of time, but I want to touch upon maybe one more question directed to all of you, just to share your thoughts on drug repurposing as a strategy for finding new blood cancer drugs. So this is a question that has come from the audience.
I'm happy to opine first. The chemical dictionary out there is filled with hundreds and hundreds of thousands of chemicals. And there are strategies where drug repurposing, i.e. maybe using a drug to treat an infectious disease, might have some anticipated effect in a malignant disease or an autoimmune disease. I view it as an element or a contribution from that realm of chemicals or drugs in a library that should be added to a broader process. So I think it's a pool of small molecules that should be interrogated. And as I showed you, we have a strategy where we're looking for drugs that complement each other in very unique ways. And if that happens to be a drug that's approved for another indication, so be it. If we can understand that mechanism of action, that's great. But a reliance on simply interrogating and evaluating repurposed drugs as a sole strategy is probably not one that I would put a lot of credence in. I think it's a component of a multifactorial drug or chemical screen that should be integrated into a very logical and rational drug discovery process.
Yeah, I think that's a great summary. I don't really have anything to add other than to state that all the drugs used for LGL leukemia are repurposed. So I've been doing that for 40 years.
I would say a lot of it, I hear repurposed drugs, and sorry, I'm on the medical campus, so you're getting some sirens in the back. are really based on drugs that have what I would consider an old shelf life. So if you look at some of the stories that Owen talked about with pralatrexate and romidepsin being pulled from the market, based on not having confirmatory studies through the FDA, is that drug is still available, is still very active, but needs another way of looking at it, but there's no money because it's off of its patent, et cetera, et cetera. There's no interest within pharmaceutical companies to look at these drugs. So I think there are pathways to utilize old drugs in a new manner, or whether that's old drugs in a new manner or just looking at them in a different confirmatory evaluation. And I think that's an important aspect to some of the things that we do. And even in combination, so all of these drugs, particularly in T-cell lymphoma, are approved as a single agent. So, but we know that they don't work perfectly as a single agent, and there needs to be other things that can be managed. So, could we repurpose them by either adding new drugs, changing their formulation, changing their drug delivery, changing their dose to then be evaluated that could improve patients' outcomes better? I think there's a lot of promise there. I agree completely that that's not the only armamentarium, because it loses out on many different new things that are being developed that could be very helpful also.
I'll add one more quick sentence. The rate limiting factor to impact cancer is not our ability to design the new drug, right? Chemists can do this amazingly fast. And there are so many sophisticated tools, from mathematical modeling of chemicals and proteins and all sorts of really fancy analytical methods. And now AI is out there. And I'm reading all sorts of articles about, will AI replace Owen as a drug discovery machine, And the answer is all of these things are going to work together. And when I hear repurpose, I think drugs with different mechanisms of action, but trying to interrogate those drugs in the context of our new understanding of how to look at these drugs, I think it's all going to represent a pool of opportunity that we'll be able to evaluate really efficiently and fast to be able to move these things along.
Well, thank you, everyone, for your insights. That was great. So we have run out of time, and I'm going to turn things back over to Coralie to just share some closing remarks. Thanks, Coralie.
Thanks so much to all of you for joining us today, and we are so grateful for your interest in UVA cancer and the work we're doing here. We weren't able to get to everyone's questions, but we did cover many important topics, and we look forward to sharing the full recording with you all after in a follow-up email, as well as more information on how to learn more about clinical trials and other discoveries going on at UVA, as well as how you might be a part of the science with us and support us as we seek to find better treatment options for patients. Thanks so much for joining us, and we really are grateful for the philanthropy that has enabled this work and the donors who made it possible. The Translational Orphan Blood Cancer Research Initiative would not be possible without significant funding, and we are truly grateful. Rare blood cancers need support. It doesn't come from a lot of typical sources, and we're just really hopeful that we can continue to keep moving forward. So look forward to sending you more information shortly, and don't hesitate to reply with questions or thoughts to that email. Thanks, and have a wonderful day.